Hello everyone, this is Jinia, Manzil and Fardeen, and today we are going to present our project idea that aims to make a contribution in the field of maternal and neonatal care with the title Heart Rate Estimation from Fetal Phonocardiogram. Antepartum fetal monitoring technology is needed for immediate detection of at-risk cases in mainly low-risk pregnancy groups. Even though fetal surveillance that is performed more frequently on high-risk pregnant groups may significantly reduce the incidence of fetal deaths, prenatal morbidity, and maternal distress in such groups, the majority of stillbirths and malformation now occur in low-risk pregnancies. So fPCG monitoring is the only assessment of reduced fetal activity to identify fetuses at risk of intrauterine compromise or death, so that these adverse outcomes can be prevented, albeit poor positive predictive values. We wish to deliver relatively accurate and more accessible technology for fetal welfare testing. The fPCG audio recordings are collected with a digital electronic stethoscope placed on the lower maternal abdomen. The phonocardiograph contains various information including S1, S2, S3, S4 sounds that can be further used for the detection of heart rate. One of the main challenges is to remove noises from the fPCGs, including external noises like ambient sounds, physician consultations, and other form of internal physiological noises like cough, speech, stomach calls, and breathing sounds of the mother. Now here we can see a general pathway that needs to be followed to estimate heart rate. This includes pre-processing, murmur detection, boundary detection, and component identification. We evaluated our algorithm on the Shiraz University Fetal Heart Sound database published in 2017, including 112 manual annotated audio recordings.
In the first algorithm for heart rate detection, the PCG recordings were initially passed through Butterworth filters. From the resulting signals, the spikes were then removed and the homomorphic envelograms were extracted and then self-autocorrelated. The resulting peaks were detected from which heart rate was calculated. This process was very fast, used little processing power, and gave moderately accurate results. However, the algorithm is hyperparameter dependent and gives unpredictable results to noisy recordings. The accuracy of the algorithm without accounting for anomalies is 86.6%. In the second algorithm, the process described by Schmidt in his research paper was implemented. The algorithm was hyperparameter independent and used little processing power, but the algorithm is dated and did not include any diseased patients in the study. The accuracy of the algorithm without accounting for anomalies is 85.3%. In the third algorithm, a logistic regression model was trained on a hidden semi-Markov model equation using features extracted from the PCG recordings as input. This algorithm gave high accuracy results and was hyperparameter independent. But the algorithm used high processing power and produced results with more anomalies. The accuracy of the algorithm without accounting for anomalies is 96.83%.
In future, we want to train HSMM model with ECG annotated fetal heart sound data for better feature extraction in diagnosis and prognosis of different fetal anomalies. And for that, creating a rich annotated fPCG dataset is in our future plans. Also, we want to develop a low-cost antenatal fetal surveillance device that can be easily operated by NGO rural healthcare providers while routine checkups in the remote locations. As our providers are not skilled, our device should be app-enabled to take decisions like normal FHR in case of unclear readings, recording the fPCG for offsite screening, or detecting at-risk patients from the abnormal FHR.